I shall be presenting a case of subfoveal cysticercosis, aptly titled The Curse of the White Pearl. A 34-year-old female patient presented with diminution of vision in the right eye since 5 days. The best corrected visual acuity in the right eye was 1 meter and in the left eye was 20/20. The anterior segment exam was unremarkable in both eyes. On fundus exam, there was a live subfoveal cysticercus cyst or the cursed white pearl, which showed movement on subsequent fundus photos. On OCT, the cyst was lying bang under the fovea in the subretinal space, creating a small neurosensory detachment. After neuroclearance, surgical removal of the cyst was planned. The surgical plan was to use a 41 gauge cannula to inject subretinal BSS and create a macular detachment. This is followed by PFCL injection to displace the cyst temporally and finally extract the cyst through a temporal retinotomy, saving the fovea. Now let's see how the surgery really went. Notice the subtle movement of the cyst on shining the light towards it. After core vitrectomy, triamcinolone assisted PVD induction was attempted using the cutter. Since there wasn't much vitreous to hold on to, it was extremely difficult to get a good grasp of the posterior hyaloid even on high suction. After multiple failed attempts, due to the extremely skytic thin and strongly adherent nature of the posterior hyaloid, ILM forceps were used to initiate the PVD near the optic disc. The cutter was then used to complete the PVD and finish off the vitrectomy. The peripheral retina was then examined and no peripheral lesion was found. The focus was now shifted towards the cyst at the macula. Brilliant blue G was used to stain the ILM and ILM peeling was done. In an attempt to reduce the amount of post-operative macular drag that may result from a temporal extraction retinotomy, a large arcade-to-arcade ILM peel was done. Meanwhile, a 41 gauge cannula attached to an automated microdose injector was prepped with balanced salt solution. Keeping an injection pressure of 6 millimeters of mercury, a macular detachment was created by injecting BSS in the subretinal space at a reasonable distance from the fovea. Notice the controlled, slow and steady elevation of the fovea and the cyst. Multiple site BSS injection was done to increase the size of the macular detachment. The aim was to have a large enough detachment so that an extraction retinotomy can be made as far as possible from the fovea. But the cursed pearl had other plans, and then the unexpected happened. While injecting subretinal BSS, the cyst just popped out of the fovea like an explosive volcanic eruption, and all my surgical planning went into the trash. Let's watch that again in slow motion. After a careful analysis of the cyst, I slowly approach the retina and, as I inject BSS into the inferior bleb, the fovea gives way and the cyst erupts out into the vitreous cavity, forming a tiny macular hole. The cyst then casually sinks down and lands on the optic disc. I then use the cutter to eat up the cyst. I slowly approach the cyst on cutting mode and zoop, it went into the cutter's mouth. Since the iatrogenic macular hole seemed very small in size and the ILM had already been peeled, I was quite certain and confident that the macular hole will close. Air fluid exchange was done, 20% SF6 gas tamponade was given, followed by prone positioning for a week. At 1 month post-op, to my utter surprise, the best corrected visual acuity had only improved to 20/200. On OCT, the macular hole persisted and thus the curse of the white pearl had not been lifted. It was only after the first surgery I learned that I needed macular massage and an ILM graft to lift the curse. After learning the remedy and a detailed discussion with the patient, I took her up for a second surgery to close the macular hole and lift the curse. In the second surgery, since the ILM was already peeled, a silicone tipped diamond dusted Tanno scraper was used to do gentle macular massage near the superior, inferior, and temporal edges of the macular hole. The papillomacular bundle and the nasal edge of the hole were not touched at all. In the absence of ILM, this maneuver significantly reduces the size of the macular hole and greatly increases the chances of hole closure. Some more macular massage was done a little further away from the hole margins to loosen this retina as well. The silicone tip of a backflash cannula was then used to passively drain and oppose the edges of the hole by gently touching the edges just a few times. Additionally, an alum graft was harvested from the edge of the previous peel and a PFCL bubble was injected over it to stabilize the graft. Under PFCL, slowly and carefully, the ileum graft was then moved and positioned over the maclo hole. After proper placement of the ileum graft over the maclo hole, a slow air fluid exchange was done. To reduce the chances of any graft movement or graft loss, it is important that the air fluid exchange is done slowly. Another important measure is to keep the soft tip cannula away from the graft, preferably around the nasal margin of the disc towards the end of air fluid exchange. After removing all the fluid from the disc, the macula was dried as much as possible, making sure that the ileum graft stayed in place. 14% C3A-FIT gas tamponade was used, followed by 1 week of prone positioning. 1 month after second surgery, the best corrected vision had improved to 20 by 120. The OCT showed a closed macula hole and the outer retinal layer integrity was disrupted. At 2 months, the vision had improved to 20 by 80. The macula hole was closed on OCT and the outer retinal integrity showed some improvement. And at 3 months, the best corrected visual acuity had improved to 20 by 60. The macula hole was closed on OCT and the outer retinal layer integrity showed significant restoration with a small central defect left in the ellipsoid zone. To summarize, the patient went from having a subfoveal cysticercosis cyst to developing an iatrogenic macular hole and eventually had the macular hole closed. She had a good final visual outcome as her vision improved from counting fingers at 1 meter on presentation to 20 by 60 after the second surgery. At last, the surgeon and his team emerged victorious and the curse of the white pearl was finally lifted from the patient. Thank you.